Welcome back to Sketchy Farm, where today we're getting our green thumbs on and making our way to the hothouse. In this sketch, we're going to dig up the dirt on selective estrogen receptor modulators, or SERMs, and aromatase inhibitors used primarily in the prevention and treatment of estrogen receptor-positive breast cancer. Makes sense to start with estrogens, right? Well, estrogens are pleiotropic steroids that play a regulatory role in a wide range of physiological processes, from reproduction and sex determination to lipid metabolism. Estrogens are synthesized from precursor androgens by the aromatase enzyme, specifically CYP19A1, which is present in fat, liver, muscle, and breast tissue of postmenopausal individuals. Our aromatic-smelling flower represents the aromatase enzyme, converting androgens to estrogen. Remember that aromatase enzyme, as we'll come back to that later in the sketch. Estrogens exert both genomic and non-genomic biological effects through interactions with one of two receptor isoforms, estrogen receptor alpha, ER-alpha, or estrogen receptor beta, ER-beta. Both receptor isoforms exhibit similar functionality and interact similarly with endogenous estrogens, mainly 17-beta estradiol. Now, not all breast cancers are created equal, though, with various tumor types and a range of different receptors involved. But overwhelmingly, the most common type of breast cancers are hormone receptor-positive breast cancers. These can be purely estrogen receptor-positive, which is most common, progesterone receptor-positive, or even a combination of both, with these receptors expressed in both the nucleus and the cytoplasm of the cell. Now, whatever receptor the tumor cell expresses determines which type of sex hormone stimulates tumor cell growth. Cells that express estrogen receptors are stimulated by estrogen, whereas cells that express progesterone receptors are stimulated by progesterone. This stimulation enables tumor-promoting transcriptional regulation of genes involved in cell survival and proliferation. It also stimulates the activation of other non-genomic pathways involving epidermal growth factor, insulin growth factor, and fibroblast growth factor. Those little purple-blue flowers look a lot like breast cancer cells, right? Due to the sensitivity of most breast cancer tumor cells for estrogen, targeting this signaling pathway is a therapeutic option for treating hormone receptor-positive breast cancer. The first of two therapeutic targets are the estrogen receptors themselves. SERMs, or selective estrogen receptor modulators, compete with estrogen for receptor binding, which in turn inhibits tumor growth. We call them receptor modulators because SERMs aren't pure antagonists. Think SERMs and silkworms, preventing the estroglow estrogen from stimulating the breast cancer cell flowers in the pot. While they block estrogen receptors on breast cancer cells, they exhibit partial agonist activity on skeletal and cardiovascular systems. This reduces postmenopausal bone loss and produces favorable cholesterol, lipid, and lipoprotein profiles. Note that tamoxifen is also a partial agonist on the endometrium, whereas raloxifene is not. It's time to relax. Why? Because tamoxifen is a SERM primarily used to treat estrogen receptor-positive breast cancer, whereas raloxifene is used as a preventative therapy to reduce the risk of invasive breast cancer in high-risk people. Note that raloxifene is also used for the treatment and prevention of osteoporosis in postmenopausal people. Therapy with tamoxifen is generally prescribed for up to 10 years after primary treatment for breast cancer, symbolized by a Roman numeral X for 10. After 5 years, switching to an aromatase inhibitor may be suitable, which we'll cover later on in the sketch. See that crab ornament? Tamoxifen increases the risk of endometrial cancer in settings of pre-existing endometrial hyperplasia. You'll definitely want to evaluate abnormal vaginal bleeding in an individual with current or past use of SERMs, particularly tamoxifen. Yikes, must be a mud swallow problem here, because look at that clogged up, muddy nest. This should remind you to keep a close eye on patients with a history or increased risk of thromboembolic events. Remember, this risk increases with co-administered chemotherapy. When using SERMs for the treatment of breast cancer, consider risks and benefits in patients with a history of thromboembolic events. Remember earlier in the sketch, we mentioned that aromatase enzymes convert precursor androgens to estrogens? Well, that makes the aromatase enzyme a great target in estrogen receptor-positive breast cancer as well. Inhibit that smelly aroma with a clothespin, our symbol for aromatase inhibitors. This greenhouse is full of wild and wonderful plants from around the world. Anastasia flowers, lotuses, and some echinacеas. Anastrozole, letrozole, and exemestane are aromatase inhibitors used in the treatment of estrogen receptor-positive breast cancer. By blocking the aromatase enzyme, aromatase inhibitors reduce tissue estrogen concentration down by 97 to 99%, meaning less estrogen is available to stimulate estrogen receptors on tumor cells. When used as initial adjuvant therapy, aromatase inhibitors are used for around 5 years. Some individuals may switch to an aromatase inhibitor from a SERM to complete adjuvant therapy, with the dosage treatment dependent on the length of time on the SERM, amongst other considerations. It's getting hot in here. Both SERMs and aromatase inhibitors can cause hot flashes, which can present as a sudden feeling of warmth, usually most intense over the face, neck, and chest, as well as profuse sweating. Both classes of drugs are also associated with vaginal dryness, but this is more common with aromatase inhibitors. Other common side effects of aromatase inhibitors are joint, muscle, and back soreness. And from the looks of it, she sure does look a little sore. And see those decaying table legs? They look a lot like bones. Reduced bone mineral density is also common with aromatase inhibitors. Bone mineral density should be measured at baseline with calcium and vitamin D supplementation, recommended for all patients taking aromatase inhibitors. Further monitoring and treatment depends on baseline bone mineral density and other risk factors for osteoporosis. And finally, SERMs can also commonly cause nausea. He does not like the smell of that aromatic flower. Could someone pass me the clothespin? Well, let's quickly recap on what we've covered at the hothouse today. Estrogens are pleiotropic steroids that play a regulatory role in a wide range of physiological processes and are synthesized from precursor androgens by the aromatase enzyme. Estrogens exert biological effects through interactions with estrogen receptor alpha or estrogen receptor beta. The most common type of breast cancers are hormone receptor positive breast cancers, of which estrogen receptor positive breast cancers are the most common. We know that cells that express estrogen receptors are stimulated by estrogen, and this can be blocked by SERMs, which compete with estrogen for receptor binding, thus inhibiting tumor growth. SERMs also exhibit partial agonist activity on the endometrium, skeletal, and cardiovascular systems, which reduce postmenopausal bone loss and produces favorable lipid profiles. Tamoxifen and raloxifene are SERMs used to prevent and treat estrogen receptor-positive breast cancer. Therapy with SERMs is generally prescribed for up to 10 years, and tamoxifen with an increased risk of endometrial cancer in settings of pre-existing endometrial hyperplasia. Remember that SERMs increase the risk of thromboembolic events, so consider risks and benefits in patients with a history of thromboembolic events. Along with SERMs, we also have aromatase inhibitors, which block conversion of precursor androgens to estrogens and include anastrozole, letrozole, and exemestane. Aromatase inhibitors are generally used for 5 years. Both SERMs and aromatase inhibitors can cause hot flashes and vaginal dryness, whereas aromatase inhibitors can cause joint, muscle, and back soreness and reduce bone mineral density. And finally, SERMs are commonly associated with GI upset. All right. That's enough gardening for me. You've all exceeded my expectations with your attention today, beyond belief. Never a dull moment around here.